Well, welcome everybody to Talking Public Health and Public Health Series. We are very fortunate today to have with us Dr. Andy Subica. He's going to be talking about community engaged research to address health disparities, and he's visiting from the University of California, Riverside School of Medicine. And Andrew.
Andy. Oh,
Andy.
Andy. I'm escaping as she's talking, not the notes.
Andy is an associate professor of social medicine, population and public health at the University of California, Riverside School of Medicine. And he's the founding co-director for the U.S. Veterans Affairs Center for Pacific Islanders Veterans Health. His research addresses health, mental health, and substance use disparities in underserved populations, including communities of color, public health, or public mental health consumers, and unhoused individuals. He has a bachelor's degree from Pomona College in Claremont, California, and a master's and doctoral degree from the University of Hawaii. It's kind of nice.
Yeah.
I was Southern Illinois. So anyway, it's great to have him here. We're very excited to hear his talk, and he likes to walk. So please make sure you can hear him. You're gonna start out, and if you can't hear, let him know. We'll work with that. Thank you.
All right. Hello, party peoples. My name is Andy, and I'll be doing community engaged research to address health disparities. But Deborah's right. I do like to kind of not be stuck behind the podium. But can you hear me? Anyone have any to?
How about on Zoom?
That was my only concern. We will see. Okay, I will try to project. And we'll see. No, it's really nice. I was talking to some of the graduate students about how this is like a cathedral type atmosphere. And I think that's really interesting. And you have a grand piano. So very impressed by everything. So, okay. I want to make sure to kind of go. I have about 40 minutes. So I'll try and keep it under 40 minutes to leave time for, how did that go? For questions and discussion. So I'll go fairly quickly through some of this stuff. I might try and skip based on what the timing is like. But this is a presentation to the fancy new College of Public Health. Congratulations to y'all for your new College of Public Health. And I want to thank you for just bringing me out and coming here to see me today. So I'll first just really very quickly talk about myself. I don't like that very much, but I got my degree in clinical psychology from the University of Hawaii. And then I did my first research postdoc at University of Southern California in their Clinical Translational Science Institute, and also in their School of Social Work. And then over the past decade, I have been at School of Medicine doing population and public health. The main through line is basically that my work is very interdisciplinary. My experience is very interdisciplinary over time. And then I, over the past couple of years, have started to co-direct and start a national VA Center for Pacific Islander Veterans Health. And we have
Sorry,
that was
we need to share the screen.
Yeah. And so this was our fancy logo, but the only reason I'm showing this is what the VA PR people came up with. But just yesterday, we got our renderings for our,
I'm going to distract you for one moment. We need to share the screen.
yes.
Oh, look, we did. Thank everybody for their patience.
Okay, perfect. Okay.
It works.
Yeah.
You don't.
You don't see. So then we have this fancy new, we're still trying to decide between this one and this one. Our brand marketer was kind of doing a fancy job. Those are skills I do not have, but what you may be able to tell is I like visuals a lot. And honestly, I'm supposed to do a good research talk, but my goal is just not to put you to sleep for 40 minutes. So let's aim for that because lunch is kind of a food coma time. And my work right here is around community engaged research and health disparities. Can you all see me? Is this fine over here, first of all? And now you can hear me, hopefully? Okay, good. All right, so community engaged research, CDC called it the process of working collaboratively with and through groups of people who are affiliated by geographic proximity, special interest, or similar situations to address issues that affect the well-being of those people. The key part here is when you hear the word community, many people think geographic community. So St. Louis, I do work in South LA or Skid Row, but there are also communities that are broader than that. So I also do work I'll talk about with Pacific Islanders in Arkansas, in the Pacific, in Hawaii, in California. That's also a community, even though it's not geographically bound. The things that I like about community engaged research is that it is collaborative. It is a collaborative research approach between academic and community partners. And the goal is to address issues of local community need and concern. Now, we do consider issues around generalizability, but you are really supposed to be focusing on the specific community's needs that you're working with. Also, I like that it's not a deficit model. It's you recognize and leverage community strengths and resources. And my favorite part is you seek to build community capacity either to do research or more importantly, to affect change in some ways through community engaged research and community-based participatory research. My work within this realm focuses on mental and physical health disparities in disadvantaged populations. Simply put, health disparities, most of you know this already, are group differences in health status that result from social, environmental, or economic disadvantage. The concept of disadvantage is inherent in the term disparity. So if you are doing disparities, you aren't just working on health differences, you're working on health differences with groups that are experiencing some form of disadvantage. And one thing that I get sometimes is, why do I do both mental health and physical health? And that's really interesting because we intimately know that mental health and physical health, they operate in tandem, right? We understand this, research is growing, that we understand this. And yet in the US, mental health and physical health still remain very siloed. You know, example I say is imagine last time you went to your doctor's office to get just an annual checkup. You know, did they ask you if you were feeling depressed? Did they ask you if you're feeling anxious, suicidal, about drug use, alcohol use? I don't mean on screeners, I mean literally in the patient encounter. Did they ask that? Typically the answer is no. And that's problematic because we understand that mental health and physical health are deeply intertwined. You cannot separate them. Other cultures have this concept of mind-body, if you've heard of this. So they may innately understand some of these connections. But we do not treat healthcare necessarily the same way, even though we try to make advances in integrated care. I've seen these kind of things. But the other thing is that mental health and physical health do not work in isolation, but they're deeply influenced by the conditions in which we live, right? These are the social determinants of health. So for the disadvantaged communities that I work with, they often encounter issues around lack of clean air in Southern California, lack of clean water, low income poverty. And then also now a really pressing issue is lack of housing, housing insecurity, as well as all the things that thrive into this, food insecurity. I know that that's something that people care about here now. So that's a primer. What I'm going to talk about now are things within the health disparities community engaged research space that I kind of focus on. And the first one I'll talk about is more around interventions. So I am a clinical psychologist by trade, which means that I was kind of trained to focus on intervention, which is why implementation science makes sense to me. But CBPR is slightly different. The intervention space doesn't always connect. So I'm going to be talking about just a couple examples. There are many ways to do this. Just a couple examples from my work of how you might be able to blend CBPR and developing these evidence-based community-informed interventions. And to do this, I'm going to introduce this group, Native Hawaiians and Pacific Islanders. Have people heard of Native Hawaiians? On the East Coast, no. West Coast, to some degree, sure. What's interesting is Native Hawaiian Pacific Islanders are the smallest of just 6 federally recognized U.S. racial groups here in the U.S., but they're the smallest. And there are about 1.5 million who live in the U.S. right now, and over 10 million in the Pacific, often in U.S. affiliated territories. But marrying Indigenous American Indians, Alaskan Natives, Pacific Islanders have endured extensive historical trauma and loss. This is exemplified by the U.S. military-backed overthrow of the Hawaiian monarchy in the 1890s. But very few people know more about the many other cultural traumas perpetuated on Pacific Islander people by the U.S. For instance, Over a 12-year period after World War II, the US military detonated the equivalent of 7,200 Hiroshima-sized nuclear weapons in the Marshall Islands. The problem is that they failed to adequately evacuate some of the Marshallese people. As a result, generations of Marshallese lands, food sources, and individuals were exposed to radioactive fallout. And you can see the health effects even today in the communities I work with, even in places like Arkansas, Oklahoma, Seattle. But when I first started working with this group, it was suspected at the time that much like Indigenous American Indians, Alaskan Natives, Pacific Islanders might have these high rates of mental health problems such as depression, anxiety, substance abuse, and suicide. But there was a real big issue. There was almost no empirical data to support this. It was anecdotal. So we really had to just kind of build this field of research from scratch. And in order to do that, one of the main things that ended up happening was, so I'm a clinical psychologist again, so I'm trained to think manuals. I develop a cognitive behavioral treatment for depression. We do fidelity. We make sure that it's implemented correctly and that we're doing it right. We're doing it evidence-based. But one thing that happened was when I started working with the Pacific Islander communities, the feedback they gave me was, Andy, you can create all of the interventions you want. We are never walking in the door. And that's what I was talking to, flat out. And so where does the healthcare system come in if we're not reaching the community? This is really when I started to focus more on community engaged research, and I'll talk about this. And in order to develop what I call culturally grounded interventions, I developed this methodology that I call citizen panels for health equity. Now, it's not mine. I pulled this from public policy and political science. People have done deliberative democratic methods for a long time. But basically what this is a deliberative method that engages residents and stakeholders from the community in informed deliberation and decision-making so that they can adapt current public health research and interventions to actually be more accepted, more feasible, applicable to disadvantaged communities. And me and my colleague, Dr. Brandon Brown, we published this in American Journal of Public Health a couple of years ago, but it is a qualitative method. The main difference between other qualitative methods is it's not necessarily just information gathering. We are driving people to make decisions from the community perspective. So there is a decision-making process that is really the outcome that we're looking at. And so all sit-in panels are is you convene 15 to 30 community members and you present them first with a topic so that they can make informed decisions. And then they split into these breakout groups. They deliberate about the options that you give them, that you want them to make a decision. They make decisions in their smaller groups. And then we reconvene, share our deliberations, and reach a panel-wide or community-wide consensus. So how does this really look? So this is me doing this in Springdale, Arkansas with the Marshallese community. I'm presenting, I think, about depression and anxiety. Because for instance, when we think about depression, we often think about, when you think about depression, colloquially, I think people think sadness, right? But depression is actually a constellation of multiple symptoms, many of which look nothing like sadness. So, these are things we have to kind of work with community. But what we ask them about depression is we want to make sure that they have a recognition. So we did these citizen panels and we basically, very basic, we asked them, what are the 3 biggest issues that are affecting your community? What are the barriers to seeking treatment in your community? Because we need to understand what the barriers are if we're going to overcome them to increase treatment seeking. And then to choose which evidence-based interventions work best for them and how to integrate the preferred cultural practice. And they identified 3 core barriers. They did a wonderful job. First is stigma. We kind of knew this. Second was limited mental health knowledge or literacy. For instance, they had very specific cultural beliefs around what caused mental illness, such as sin, lack of faith, ancestors. And they also thought things like bad blood. So a common treatment in their mind that they get recommended was prayer or faith, as opposed to interventions. And then the last one I thought was really interesting, and this became important, was unfamiliarity with the treatment process. And I think this is honestly for many groups. They had understandable concerns, such as how much did it cost? Was it confidential? What does a session look like? And one thing they did that was really interesting and drove what we did was we asked them, how do you want this intervention to be delivered? Do you want it to be a group intervention, a single intervention, web-based? Do you want it to be with photonovelas, and they all unanimously picked one thing, which is narrative film. So narratives, for those who don't know, is stories. And I work with a person, her name is Dr. Sheila Murphy at Address School of Communication. And she does this really interesting thing, and I'm gonna do it with everyone here. I'm gonna ask you two questions. And don't answer out loud, just think to yourself, to which answer comes quicker, okay? To your mind. The first question is, what makes Pinocchio's nose grow longer? Second question, what was the name of your second grade teacher? Who had the idea, the answer to the first one pop into your mind quicker than the second? Okay, what's the answer? Do people know? Yeah, okay, funny. I actually still don't remember my second grade teacher's name, to be honest, but I spent 9 months to a year. This is my own personal experience, but I can't access it the same way that I could a fictional story or a play or a book that you read. Because there's something powerful about narratives that really works. And there's a science behind it. And I'm talking to some people who know health communication pretty well. And so narratives are empirically demonstrated to create greater, longer lasting impact on health knowledge, attitudes, and behaviors than traditional approaches, such as PSA, public service announcements, brochure. And they work through many mechanisms, but quite honestly, it's by transporting audiences into a fictional storyline. These narratives trigger deeper cognitive processing, but also manage to better circumvent negative reactions and counter arguing. We always have this natural human reaction to resist when people tell you what to do, what to eat, what to think. And so testimonials are good. You often hear those for like anti-stigma. They're actually not as effective as fictional storylines. And I could spend a long time talking about this. And I'm sorry, I do not know what these lines are about. Yeah, I think it's artifact. But based on this information, we created this didactic manual with culturally grounded education, entertainment, films. That was a little bit of the manual. And I'm just gonna go in for a little bit of time and show you some of this process, because I never thought for an NIH grant, I would become basically a filmmaker. But that's what we ended up doing. So we worked with professional filmmakers and we spent months developing the script, which is not easy to do because I can't just say, here's what depression is, and then people are engaged. It has to be someone engaged. Then we did auditions for all of our roles. All right, well, so that's one of our actors. We basically did a male and female film on the same topic because our community again guided us. They said, well, you need to have a film with a male character and a female character. And it gets really dense when there's a hero character, there's like all these different like templates. But that was our male character. Then we presented what we did a dry read on Zoom where everyone just kind of recited it for the first time to get to know the script. We presented to our advisory council and they loved it, except they had one correction. Our main female character, they didn't like at all. They didn't think worked at all. So they actually had us start over and recast our female actress for this. And so we ended up recasting. This is now Moana. You'll see her in a little bit. But then we went to Hawaii and we did a rehearsal.
Well, let me guess. They get all the floor.
So the important part is not just the rehearsal, it's blocking, cinematography. This was a chance to like set everything up with scenes.
Hey, nephew, good to see you. Yeah, come work with an appetite. Top.
Yeah. When has that looked at you sad when you were spoken for time?
I'm gonna skip around. I don't want to use all our time.
These are good. When I hear you. That's my boundary. It's closed. The things fell apart, and I went through a really rough time in my life. The stress was overwhelming. I couldn't stop worrying, and got real down on myself. I felt worried.
And so what's interesting is after this phase, we recorded this and we did citizen panels to ask them, was this compelling? We had a number of questions. And what's really interesting was they loved most of it. And the reason I wanted to show this was they actually had a lot of critiques about the male character here. They said he was weak, he was not Pacific Islander enough. They used words like he's not a man. And I don't know if you noticed, but because he's very like subdued in this. So actually they gave us guidance on how he had to be a bit more kind of outward facing. They had anticipated this. So this did not resonate with them at all. So we had to work with Russell, the actor, to kind of develop this. And then we shot over a week in Hawaii, and then I will show a little of this. This is the final product. We're actually now pilot testing this in a randomized controlled trial in advance of like an R1.
You're sitting over here by yourself. You want yourself a friend. Is there anything we can do? Not because you should see. Damn 3 times enough. See you for a while. Girl, don't be silly. I'll be sure to you. No, it's okay. I'm not hungry. Hey. Why don't you come in the kitchen and hang out with your dad?
Oh, don't tell me. You ran out of food already.
Don't worry, Dad. Everything is all good. But look who I brought into cover. I saw her saying, "Oh,
Hey, Sina. Good to see you. Oh, huh? Well, come, keep a break from public.
Okay, so I'm gonna skip that part, but I'm just gonna show a little of this. Remember that they said it wasn't just around the stigma, it wasn't just around mental health literacy, which that whole first video was. Well, it was about what does treatment look like? What are these very foundational things we haven't really seen in the literature, I've actually seen around what do you do to engage people? So we have to film things like this. And this is actually one of the most successful parts of these films.
Matthew is finishing up with another patient, so can I get your ID and insurance form? If you have insurance.
So, how much is this visit gonna cost?
Well, we accept most health insurances, which should cover most visits. And for anyone without insurance, we adjust the cost based on your income. I'm happy to help figure it.
So again, for time, I'm gonna skip this, but it's been really interesting because as much as we've been trying to keep this, like, you can't basically show it to the community because that's contamination for future trials. We have been actually screening this in select cases. So for instance, in Molokai, which is an island in Hawaii, they had a suicide. So they had a community kind of forum, a grieving session. They asked if we could show things like this. Of course, right? So we're actually kind of just already launching some of this. But we also unfortunately still have to be careful with the science part of this. One thing I want to talk about very briefly is, and now it's going to get pretty quick for y'all, is in my interview, I was hearing discussions about substance use being important of interest. So I'll give another example of an intervention that's a different area, substance use. So this was also at Native Hawaiian Pacific Islanders, and we basically were seeking to develop and pilot test an opioid and methamphetamine treatment engagement intervention for Native Hawaiians and Pacific Islanders. So similar to mental health, we want to adapt this because methamphetamines were becoming have been a big issue for some of these communities. And you think people don't seek treatment for mental health, like substance use is a whole different world. So we have to figure out a culturally grounded way to do that. So during the pandemic, we did these online surveys national with about 300 individuals around things like substance use. And then also we asked about vaccinations and COVID-19 outcomes. So we published that. But the problem with this, when I've been presenting this like for NIH HEAL, like the substance use, is when we looked at substance use in the community population, we had 5% prescription opioid use, not even disorder, just opioid use, 1% methamphetamine use. So we were talking to National Institute of Drug Abuse and we're saying, okay, how do we do an intervention when we can't even find this numbers? And just so happened at that time, when I was talking to colleagues in Hawaii, Hawaii was going through a drug overdose epidemic. And they said, well, can you start looking at this? So right now in Hawaii County, a person dies every 11 days in a rural area from drug overdose. So we then talked tonight and we shifted it. So we did the first homelessness unhoused study of individuals chronically unhoused. And we did about 162. We went to parks, encampments, things like that. And here's what we found. 77% were Native Hawaiian Pacific Islander. Only 13% of people in Hawaii County are Native Hawaiian Pacific Islander, but 77% in our sample of chronically unhoused were Native Hawaiian Pacific Islander. When we looked at their substance use, this is where we found Native Hawaiian Pacific Islanders who were struggling with opioid and substance use. So ultimately, they also had major depression. We ended up writing this up, but this was the lab. I think I've been telling people I don't have an office on campus because this is lab. We're going here, we're doing interviews, we're doing surveys. And I just want to give credit, Sammy Sampaga. So he is an activist and we trained him to do these kind of interviews and surveys with us. And so he led the charge. And we're just wrapping up this pilot that we're doing. This is going to close this grant. It's a 3-month pilot test with an outreach worker to increase treatment readiness and engagement, because they basically told us exactly what we had to do when we interviewed people from this. But it's not just an outreach thing. We really had to build a menu of culturally responsive tools, things like that, in order to engage this community. And so this is when this is all outreach workers, but this is one of the encampments. And everyone you see on video is an outreach worker. You're not going to see any of them. So it's a pretty interesting setup. And then I like this. Mostly because if you see these things, these are actually paraplants. They call them kala. These are Native Hawaiian agriculture that is very connected. So they have already been doing some of this on their own in these encampments, reconnecting with their kind of cultural roots. And I'll talk about a little of that when I talk about cultural trauma. For time. All right. I'm going to kind of go through this quickly so I can just talk about that because we started a little bit late. Also concurrently, I'm going to go through this really quick. This is some of the new stuff I'm starting to do. CRISPR in public health. So this is this new gene editing tool. Basically, it's Nobel Prize winning. It repurposes bacteria's CRISPR immune system. But basically, it's this very powerful, innovative, cost-effective, time-efficient way to edit genes. And
We turned out to have a remarkable scientific breakthrough.
this just came out today.
13,000 years after the last dire wolf walked the earth, scientists say they've now brought them back. Here's our
Literally
chief
this
national
morning,
correspondent back up with the video tonight.
Tonight, a how 13,000 years in the making. In a first for science, biotech company Colossal Biosciences says it brought the extinct direwolf back to life, a species that hasn't walked the earth since the Stone Age.
The direwolf is the first extinct species.
Well known from HBO's hit show Game of Thrones. ABC was given exclusive access into Colossal's lab in Dallas, where scientists are using genes from gray wolves to create.
So CRISPR, very powerful. It is already kind of revolutionizing some of the space. You're going to see it next year. So I thought this was fascinating. But me being me, I also thought that there were real issues around inequity that we're looking at in the future whenever a powerful technology comes out. And I'm gonna talk about fundamental cause theory next. But this was a big concern for me. So I ended up writing a paper because it's not really discussed in public health at all around this CRISPR, even though it's big in medicine. There are over 7,000 studies that have cited, in fact, I think it's over 10,000 studies that have cited CRISPR at this point. But, you know, ethicists, and in this paper, we're calling for the use of CRISPR being grounded in principles of fairness, justice, and access to ensure health equity. CPR, of course, my focus, I think, is ideal for advancing equity in CRISPR gene editing, because I think there's like an early window that we need to intervene at this stage in order to make the resulting products more accessible for communities. This one I'm going to go through really quick. In fact, it's something I'm working on right now called community-based participatory science, which is a deep cut. It's a new, I'm trying to think about and develop a new classification system for conducting CBPR studies that integrates established scientific methods and designs. I'm really going to go through this fast. I think there are key gaps in CBPR in rigor and reproducibility. Currently, CBPR is not considered a method. It's not considered a science. It's considered an approach. If anyone, very clearly, it's stated to be an approach. And because of it, I feel like over the past 50 years, because CBPR has been around since 1970s, it first started to emerge, there still doesn't really exist, in my mind, a uniform understanding or guidance for how do you implement rigorous research methods with CBPR. It's still kind of all over the place. And I think CBPR is essential, especially in this context now, because it can enhance health equity by bridging scientific methods with innovative community strategies. The strategies that I think are coming from the community. I have like a little figure I developed around certain types. The last one is implementation science for implementation scientists. And I might add a fifth one around program evaluation, because that's also very important in like CBPR spaces to have a program evaluation element. But I'm going to finish with this. So talking about cultural trauma, I promised one of the graduate students, yes, I'd finish with talking about cultural trauma. So several years ago, me and my colleague, Dr. Bruce Link, we developed this paper called Cultural Trauma as the Fundamental Cause of Health Disparities. And so in order to really talk about this theory, I need to talk about fundamental cause. So 30 years ago now, my colleague, Bruce Link, and his wife, Jo Phelan, they created something called fundamental cause theory in this paper. Some people may know it, social conditions as a fundamental cause. And they had 3 tenets, and it's a really interesting concept here. And it is that health disparities persist over time in the exact same groups, regardless of changes in diseases, risks, or treatments over time. So whether it was smallpox and cholera hundreds of years ago, HIV/AIDS in the 90s, COVID-19 more recently, Mpox, you are still seeing the exact same groups be afflicted by this and experience disparities. And the reason they felt was that as new diseases occur, let's say COVID-19, individuals with higher socioeconomic status have better resources to avoid these risks. And they call these risks flexible resources because they can be used flexibly in multiple ways to protect individuals from changes in diseases, regardless of the disease. You have these resources such as money, power, knowledge, prestige, beneficial social connections, and freedom. You can more flexibly avoid diseases. So this is fundamental causes. Now, in the literature, before we started this work, there have been basically 3 fundamental causes that have been codified, really well established. The first was socioeconomic status in the original paper, stigma by Mark Heisenbuehler at Harvard, and then racism, racial segregation by Dr. David Williams, and then Dr. Link. And so I actually felt through my experience and working with my communities, they kept saying, Andy, we are doing all this stuff around depression and health, but we're not engaging with cultural trauma, historical trauma, all of these things that we're experiencing. Can you think about this? So we ended up sitting down, and I felt like there was a 4th fundamental cause that was under-discussed, which I call cultural trauma. But I define it in a very specific way. I define cultural trauma as an overwhelming physical or psychological assault or violence on the culture and cultural resources of a group of people sharing a specific group identity or affiliation. So historically, I've been a trauma psychologist, and when we think about interpersonal trauma, it's trauma against an individual, right? Their health, their harm, their mental health in some ways. I feel like on the population level, what is really impacted and what kind of perpetuates over time is when a culture is damaged itself. And there's a really interesting concept, Bruce said it when I was explaining it. He's like, okay, it's like water to a fish, right? You don't notice the culture around you that permeates around you, but you take a fish out of water and they flop around and die. And that's what we've been hearing from a lot of my communities that I work with when their culture is affected. The challenge with cultural trauma is it doesn't happen in isolation, but it's enacted and maintained by a oppressive dominant group, in which the dominant group doesn't just do it for fun necessarily, but they perform cultural trauma in order to exploit and subjugate the culturally traumatized group to further the dominant group's interest in some way, whether it's gaining reputation, so the age of empire, or actually resources. And we have seen this over time, right? The enslavement, kidnapping, African people, the genocide of indigenous American Indians, Holocaust, the internment of Japanese Americans in concentration camps. But the reason I call it cultural trauma is we often think historically, but we are seeing these assaults on people's culture going on today, type of thing. And we need to come up with, I needed to come up with a model that does both historical and contemporaneous and future kind of acts, which don't necessarily involve active violence, genocide. And so I wrote that cultural trauma damages or devalues three elements of a group's culture: modes, institutions, and lands. And so what are cultural modes? There are ways of operating, living, behaving, and experiencing the world. This is basically what we consider culture. You know, these are the values, the beliefs, the norms, the customs that construct our social and internal world. So for instance, rituals, rites of passage, these are these cultural modes, and they're important because they frame our interactions for how do we act towards others to meet our needs, and also our standing in the world. And they teach us how to successfully navigate within your society to gain resources and get your needs met. And fortunately, when these cultural modes are damaged, we've seen some negative impacts. The other ones are institutions. These are systems that establish social order and govern behavior and expectations. These are legal systems, educational, economic, religious, labor, political. And typically, cultural trauma does have some impact on the group's sociocultural systems. So for instance, for many years, indigenous Alaskan Natives, American Indians had their own ways of education, their own ways of transmitting cultural information from generation to generation. But then, as we now know, when Americans came in, kidnapped people, put them in boarding schools, we still see the deleterious effects on these communities now. I mean, you can see pictures of Abraham Lincoln, George Washington over there, but also in other places, vocational systems. So for instance, so it's not just bound to the US, right? In Southeast Asia, they had these very agrarian ways of being, this vocational, not vocational system. And then now we have seen kind of these shifts. The problem with this is that when a institution is eradicated and the culture traumatized group is brought into the dominant group's institutions, they're not typically brought in at the same level of status. They're often forced into subservient positions or low status within the dominant group systems, creating relative disadvantage. Dr. Mindy Fullilove has a really good discussion around that with racial segregation. And then living within disadvantage in an unequal system actually harms health by reducing access to flexible resources. And the last one is just cultural lands, I call it, which are the material resources, what most people think about when they think about like displacement, things like that. The thing that I think is important is every thriving group would have sufficient resources to thrive before this cultural trauma. Once the cultural trauma happens, they become dispossessed of that. And so from my island, the Native Hawaiian people, you know, they had these protests because their land was kind of taken. This is the TNT protest, the Rock came, Jason Momoa came. But even here on the continent, you have Dakota Access Pipeline, where they're doing similar things on native lands. And being denied essential material resources leads to poor health outcomes that may accumulate over generations. I love that that line is there. Okay, denial of dispossession is maintained over time through different mechanisms. I think I'm almost at time, so. Oh, we're at 45. So this is the model. modes, institutions, I'm just gonna kind of skip through this really quick, because I want to just talk about this really interesting last thing in this model. So there's something that is called multiple replaceable mechanisms, and I brought this into cultural trauma. So following cultural trauma, for everyone here, culture is incredibly dynamic. It's almost a living, breathing thing. I mean, think about how different culture is now after social media and TikTok from even culture 20 years ago. Radical difference, right, in the same community. Culture changes, it's almost living and breathing. And so for groups that experience cultural trauma, they are innately driven to heal by restoring their damaged, devalued cultural resources. You know, they don't just stay in these disadvantaged positions, not willingly. And so there is this understanding that restoring flexible cultural resources will improve health and well-being. However, the dominant group is inclined to maintain their advantage and dominance over material resources through multiple replaceable mechanisms. And this basically keeps them living in disadvantage. This is kind of a foundational thing. So a sociologist, Joe Fagan, had a really good example. So when you think about, slavery, so this was incredibly economically important to the US. There was incredible benefit. But when slavery was abolished, the dominant group didn't just say, okay, they instituted other mechanisms such as racial terror, Jim Crow, segregation. Then when these were outlawed in the US, new mechanisms arose, such as race-based policing, young African-American male school to prison pipeline, and so on and so forth. So there's this constant interplay that's occurring in kind of the society, and potentially, we're seeing some of this again, this push and pull emerging over the past few months. And you know what? I am gonna stop there. On a downer, unfortunately. Yeah. No, but I want to make sure to leave time for questions or discussion. I know, very different, by the way. Yeah, thanks.
Can you still figure for a moment how you propose the
Oh.
relationships?
I mean, it's also in a paper. Yeah. So, yeah, in social science and medicine, we can. Yeah, it does a much better job than I do talking about it. Yeah, my writing's smarter than my talking. But yeah, any questions?
I'll start.
Oh, sure.
So thank you. It's really interesting. You talked about some of the parallels with American Indians and, natives to continental US. Are there differences though in what you've seen in Native Hawaiians and Pacific Islanders? Say that again. Okay, I people online. So the question was, are there, you talked about some of the similarities, but are differences if somebody who's working with or studying American Indian populations compared to the people on that island?
Yes.
Yeah.
Yeah, huge. So if the question is, so American Indian Alaska Native is one kind of federally recognized racial group, Native Hawaiian Pacific Islanders are another. And what's interesting, and part of the reason I had to do this was when I initially did a lot of this work, I thought, hey, maybe some things will port over that have been developed with American Indian, Alaska, like Native American communities into Native Hawaiian Pacific Islanders. And actually they didn't. So there's a historical trauma loss scale for anyone who does that's very famous that, I tried to adapt in my first studies with Native Hawaiian Pacific Islanders. And when I did cognitive testing, they were not having it. It just was not relevant to them. So it's interesting because there are parallels in the colonization, the kind of health outcomes. So these like downstream effects, but the actual like triggers, the actual impacts and like the drivers were quite different because culturally they do have significant differences outside of this colonization process. However, the cultural trauma colonization does have kind of this pattern that we can see that results in kind of health and mental health disparities. Yeah, but at the upstream, it is quite different. Yeah, so that complicated my work a lot. Yes. Oh, Mary? Yeah. Okay.
Thank you. Is this on? Yeah. Okay. Thank you for that. I was curious about merging your early part of your presentation with the end, and I haven't heard a lot about cultural trauma, but it sounds like some of the interventions that you're proposing for individuals may be linked to intervening to improve cultures or populations. How do you merge those two together? Are they similar or?
No, so that's really interesting. The one thing I kind of skipped here, so the reason I wrote this was also not just to kind of blend, so the concept of cultural trauma was tricky because as I was explaining earlier to some of the students, in the literature, there's historical trauma, intergenerational trauma, mass trauma, collective trauma, cultural trauma, like they're very disparate concepts that kind of map together, but not really. And for me with this, the reason I wrote this was because I had a foundational understanding, at least that I wanted to get out on paper, that culture is this resource for health that we just don't understand. And that's what's impacted in cultural trauma. And that's why we see these things. So the interventions would then be things that actually build back into cultural modes, back into institutions and lands. And some places do this. Actually, some interventions do this. But my thing, it would be very much similar to that, where you can kind of reconnect people with cultural practices. They do this for like Aboriginal youth in Australia with the Yiriman project, where elders take them out, teach them all these type of things. And it seems to have really good benefits. So there seems to be some benefit to like reconnecting. We've done kind of on obesity intervention, we had community gardens for youth, where youth learned like in the International District in New Mexico. For instance, it's very kind of Latinx. And so there's kind of this agrarian history that is lost in an urban environment. And so we notice that the youth actually tend to thrive when they get to reconnect with kind of these cultural things. So it doesn't just have to be practices. It can also be like larger programming that we can kind of develop on a public health level to kind of address this. And hopefully that answered yours. There's a question here and then here.
Building on that, it would be very interesting to hear you talk about the studies themselves and the measures that you hope to potentially use to look at effectiveness and whether and how you built in some of these cultural components.
Oh, okay. So people heard that? That one's interesting. This is like a measurement thing. Here's what's interesting is we are currently developing a measure around this cultural trauma, the modes, institutions, and lands, which is kind of a lengthy process because there is no measure that I think captures this completely. Like we have ethnic identity that can capture some of this. We have acculturation, nativity. There are a lot of different constructs that we can, but none necessarily neatly map onto this, which is why when we tried to adapt this historical trauma loss scale by Whitbeck, which is kind of the Native American Indian historical trauma, it just did not work because it's so specific to that experience. So yeah, the ultimate goal, in fact, we're working right now is develop something that can be used across all groups because it's capturing some of these essential elements that cross all groups. You know, there are certain elements that are universal in the cultural experience that we're kind of trying to develop. And then, you know, map that onto the PHQ, the short form, you know, SF12 and those kind of things. Yeah, hopefully I answered that one. Yeah.
Thank you for the presentation. I'm actually interested in the citizens panels. So I know there's been some work done on this in the UK when it comes, especially when it comes to alcohol. Yes. And I think that trying to experiment with that on a grander scale, especially when it comes to their constitution, democracy, and they realize within those panels, they need to also have some representation because
yes.
It became harder and harder to figure out what's popular versus how can we actually manifest issues in specific groups. So I was wondering, given that what you mentioned earlier, that one slide about the percentage of people who are opioid use was 5%. If we're thinking about using citizen panels for issues like that, it's like a much smaller percentage of the population. So I'm assuming when you're having larger conversations, it's harder for those types of issues to manifest if they're only affecting like 5% of the general populations. So where does the citizen panel come in? Does it come in manifesting the problem? Does it come in when thinking about implementing interventions?
Oh, so this is the interesting. So citizen panels, by the way, not my thing. If we have policy people in here, I had a riveting discussion with the policy faculty. You know, deliberative methods have been used in public policy for a long time, political science, to basically capture public opinion and decision-making. You know, should we build a tower in your neighborhood, right? You have to educate them first on what the pros and cons are and then get a group decision. For something like this, the question is, when do we use citizen panels? Is it exploratory? Is it more developing? It can be used both. You just have to figure out what the decision is you want to drive to. So if it's something like, what are the major issues affecting your community? That would be exploratory. That's kind of what we did. Now, if it's something that's low base rate, so, there's like 5% opioid use, would I do a citizen panel with the community around that? No, I would pick, people who have experienced opioid use who are Native Hawaiian Pacific Islander to do this panel because they have that situated knowledge that we're trying to get. So that is more like on the rigorous research end, is you want to carefully select your sample to make sure that whatever methodology you use, focus groups, panels, surveys, applies to it. So it's the exact kind of same thing, it's really more around your research question. And then the panels are just a method that can help you derive some type of decision. And in my case, as you saw, it both told me what the issues were, the barriers were, but it also told me what interventions to do. I had to do narrative films. I would not have known that I needed to become a filmmaker to engage people in treatment. But it was very clear, unanimous, that that's what we had to do. And that's also why NIH really liked that approach in all of my studies, is they are telling us something that I would never know if I talked to 1, 2, 3 people, even community experts wouldn't have been able to tell me that, but I was able to crowdsource this in some ways. Yeah. I don't know how much time we have. Sorry, I'm like the timekeeper here. Yeah.
Got one.
Got one from the Zoom audience. I'm looking at community-based research, I really account for stigma, mental health, sexual health, for example, stigma can affect community, but reception, or is that a concern?
Yeah, did people hear that one? That's, it's around. Yeah, I'll try and paraphrase, I'm not exactly sure I'm gonna do a good job. So this one was around when you work with basically communities that have experienced stigma, how do you kind of conceptualize and then work with them around sensitive topics? Is that kind of the gist of it?
And how it can influence their participation and reception to the work, right?
Absolutely. There's multiple answers there. I'll just give one quick one that I think for students here especially. One thing that's really interesting is a lot of people haven't done the work with Native Hawaiian Pacific Islanders around mental health, substance use, suicide, because these are all highly stigmatized topics. And the thing that we had to kind of work through was, so anyone who wants to do this, it's not verboten. I also was a trauma researcher, and that's a difficult topic to talk about with different individuals, is in all of our work here, when we have crowds or we have groups, we do not ask about personal experiences necessarily. And that's something that we're really, because we're not really focused on someone's personal experience. It would be, what do people in your community think is the most important? Or what have you observed? Or, if we're asking around substance use, it's what would a Pacific Islander with methamphetamine, use in your community, what kind of issues would they encounter, type of thing. Now, we often know that some of them are speaking about their own experiences or family members, but we have to kind of give them that bridge. And that's actually incredibly effective. So that's one way to kind of not even engage the stigma, because we're not putting people's status at risk. And I have some papers on stigma too, because stigma is very scary for people because it threatens people with exposure to prejudice, discrimination, and status. And that's the thing you want to remove when you're working with stigma and participants, is you want to make sure there's no threat of those kind of elements when you engage them. Yeah.
Great. Thank you very much.